I'm Ross Camidge. I'm the Director of Thoracic Oncology and the Joyce Zepp Chair in Lung Cancer Research at the University of Colorado Cancer Center. KRAS mutant lung cancer is kind of the elephant in the room. It's really common. It's something like 25% of lung cancer, almost exclusively an adenocarcinoma. That's the cancer that comes from glandular tissue, which is the most common appearance of lung cancer down the microscope these days. But even within there are subtypes of KRAS mutant lung cancer, different specific mutations. The one that most people are paying attention to now is one called KRAS G12C. So that means at position 12, there's a G to C change of amino acid. Those codes are the names of the amino acids which change, and 12 is the position in the protein. And again, that's an activating mutation. And the important thing is that C at the end, which stands for an amino acid called cysteine, has the potential to have drugs bind irreversibly to it. So a number of companies, Amgen and Mirati are the two current leaders, have developed drugs which can bind irreversibly at that C in G12C, and they're seeing about a 50% response rate. That means 50% of people are showing dramatic shrinkage. Now, that's proof of principle. There are certain things we're still figuring out. Why doesn't everybody respond? Maybe that mutation exists in a context. Maybe there are other mutations around it. Maybe some people develop a rapid acquired resistance because there are feedback loops. Maybe there are some people who it responds and doesn't last very long, possibly because of those feedback loops, and possibly because they develop acquired resistance in different ways. Maybe they lose that C and get a different KRAS mutation, but we're still in the discovery phase. One of the questions is, does having a KRAS mutant lung cancer affect your prognosis? How long you're going to live, to put it bluntly? And the answer is maybe. The trouble is that when people do these kind of studies, what should they be comparing it to? You know, cancers which don't have a KRAS mutation make sense, but what is that population? You know, is that a uniform population, or is it made up of other mutations which are not uniform? The other thing, as we've started to realize when we develop anti-KRAS drugs, is even within the same mutation, there's heterogeneity. There are some people who do very well, some people who do okay, but for a short period of time, and some people who are not sensitive at all. And at least in the clinic, you always see this with KRAS. You see some people who have horrible disease that progresses through everything and is very aggressive, and other people who seemingly down the microscope and through the initial screen of molecular testing appear to have the same disease, can have a cancer that responds beautifully to almost anything you give it, and moves very slowly, and people will be alive for years. So don't freak out just with the diagnosis of KRAS. Nobody's written that rule book for you or your family member at the start. We're still in the discovery phase, and you will be too.